First patient is a 15-year-old male who took a helmet to his left wrist and suffered this Salter-Harris 2 distal radius fracture. He was neurovascularly intact. He was closed, reduced, and placed into a sugar tongue splint. Next patient is a 14-year-old male, status post fall during a soccer game, and it had a left Salter-Harris 2 distal radius fracture. Was neurovascularly intact, closed, reduced, and splinted. 72-year-old male, status post ground level fall with a right distal radius fracture. They were neurovascularly intact, closed, reduced, and placed into a sugar tongue splint. I believe so. He has a little bit of dorsal comminution. They're also 72. So I think it may be a little bit dorsal by a couple degrees, but I think with their age, I think they'll do okay as long as they don't fall more into dorsal angulation. The next patient is an 87-year-old female with ground level fall, had a right distal radius fracture. She was neurovascularly intact, closed, reduced, and placed into a sugar tongue splint. Next patient is a 60-year-old female, status post, ground level fall. This happened 4 days prior to presentation, and she was found to have this unicortical defect on the polar radial side of the radius, where she was point tender. She was placed into a removable wrist splint. This is a 44-year-old male, status post fall from a ladder with an isolated left distal radius fracture. He was closed, reduced, and placed into a sugar tongue splint. He was neurovascularly intact, and then he will follow up in the office for close monitoring. Next patient is a 14-year-old female. 4 days prior to presentation, she was seen at an outside urgent care after falling during gym class and suffering this left small finger proximal phalanx Salter-Harris 2 fracture. She was closed, reduced there, followed up in the office, and found to be redisplaced on these images that were sent in from the office. She was neurovascularly intact. She was re-reduced and placed into an ulnar gutter. She did have significant instability with this reduction, so she's going to follow up in possible pinning.
Do you have x-rays that show that it was ever reduced at the urgent care?
The x-rays from urgent care?
Yeah.
No, I do not.
Okay, because the likelihood is it was just put in a splint or not reduced, or reduced and x-rays weren't taken. So you got to be careful.
She did, per the patient and mom, she did have the areas where she was injected for a digital block and said that they did do a reduction, but I do not know at the time. Yeah, there was an x-ray of it like 90 degrees sideways sent in from the office as well, but I did not see a post-reduction x-ray. Next patient is a 9-year-old female, status post, ground level fall with this right LC1 pelvis. She was neurovascularly intact and made protected weight bearing on that extremity. Next patient is a 28-year-old male who suffered an injury at work where a pallet jack ran over his right foot. The x-rays originally were negative, and then a CT was ordered, which found this right lateral cuneiform fracture on the plantar side. He was kept for about 4 to 6 hours after, just to monitor for any sort of compartment syndrome due to the mechanism. He was neurovascularly intact and placed into a posterior splint and made not weight bearing for pain. And that's all. I think it was. I gave him strict instructions what to watch out for and to return if there was any sort of symptoms, but how long would you recommend?
Morning. First patient's a 17-year-old male who sustained a fall, had a right distal clavicle fracture. He was neurovascularly intact and placed in a sling. Next patient's a 71-year-old female who had a fall, sustained a left proximal humerus fracture, was also placed in a sling, sent out for follow-up outpatient.
Can you describe the fracture?
Yeah, so this looks like a two-part near fracture with a surgical neck. Looks like there might be a little bit of involvement of the greater tuberosity as well, but it doesn't seem displaced.
Is the head in varus or is it an anatomic position?
Looks like a little bit of varus impaction, maybe, with the proximal end of the shaft kind of impacted into the head.
Would the results of repairing that and reducing it anatomically and fixing it afford improvement in function over treating it like this?
I think it could, but given the patient's age as well as she's relatively low functioning, I don't know if the benefit would vastly make the surgery worth it.
Right. So I think you should be more than just think. You should know that the best studies that we have show that there is no difference in function, which is why you're treating it like this.
Thank you. Next patient's an 80-year-old female who had a fall, has a right clavicle fracture as well as a right scapula fracture, and a left distal radius fracture. The clavicle and scapula were treated with a sling. The distal radius fracture was treated with a sugar tongue splint. Thank you.
Morning. First case is a 76-year-old female who fell 1 month prior in Mexico while she was on vacation at an exercise class, presented 1 month after the injury with this left distal radius fracture that was in a splint. Of note, on evaluation, she was having some carpal tunnel symptoms, some numbness in her median nerve distribution that was present prior to even her surgery. So she was taken for a carpal tunnel release as well as a distal radius ORIF.
Can you explain the reason why you went ahead and did that? Was the alignment not acceptable?
So there's certainly a little bit of dorsal tilt. There is kind of some translation of the carpus dorsally. She is a very, even though she's 76, she is very healthy and active lady, and given mostly the translation of the carpus as well as her carpal tunnel symptoms, we decided that she would best be served with fixation as well as a carpal tunnel release.
So you really
Jeremy, that case is 1 month old. It's healed. It's not moving from there.
The other thing is you have to, when you're telling someone the indications, they shouldn't be your feelings. They should be based on fact. Your carpus is not translated. You have a neutral tilt as far as I could see. It's not volar like it should be, but it's neutral. The height is within the acceptable range. In fact, it looks almost normal, and your radial inclination is good. The articular surface doesn't look terrible. It's 76 years old. It's a month out. Really, it just needs a removable splint now. And you don't operate on someone for carpal tunnel syndrome. You don't fix their wrist. You operate on them for severe compression of the nerve that doesn't get better with reduction.
Right.
So you really need to know the indications. There really is no good indication for fixing this.
Understood.
No, I'd be worried too with your plate, the way you place that plate may need to come out. So now you've subjected her to a second surgery.
Yeah. This is the Synthes volar rim plate. It is, it was a distal fracture, and we had to put it pretty distally. But I think with these plates, one study I read, there was a 15% incidence of plate removal. So that's certainly a concern.
Well, I don't think
So
it's
Jeremy, if you didn't fix this and you just addressed the carpal tunnel, how would you release the carpal tunnel?
I would just release it in a standard fashion I don't know that I would do anything differently.
So for these, I find that even though it is a month out, if there is a little dorsal angulation, I would also release the antebrachial fascia distally as well. So I would do more of like an extensile carpal tunnel release with
Gotcha.
these. I don't know how the other attendings feel about that.
I think that.
So this is my case, and I did an extensive carpal tunnel release to release the antebrachial fascia as well, because we're already in there doing that with the plating. But had I not plated it, I would have done that as well, because I think they get much more of a proximal compression if they're apex volar angulation. And my reasoning for doing the plate was to make sure that there was, a stone not left unturned. I think you probably could have gotten away with not operating on it, but it was enough dorsal tilt for me. And it was about, when I measured it, it was about 10 degrees, that I didn't want to leave it like that. Her age definitely played a role, but she's a lot more spry than you would think for her age. So that was the reasoning. I wanted to get that volar tilt at least up to neutral. In the operating room anyway, I may as well.
What's the sound classification of this plate position?
It's a 2.
All right, so it's not 15%, but approximately 10% of the time plates come out. So the plate is, and obviously the nature of the fracture sometimes determines where you put the plate, but this has a much higher likelihood of irritating the flexor tendons than obviously if it was more proximal and not in the watershed area.
Yep. Next case, excuse me, is a 64-year-old male who fell 1 month prior with these left 2nd through 4th metacarpal shaft fractures. Initially trialed non-operative management. This is where he was with persistent angulation and displacement of his fractures at 1 month. So we took him for 2nd through 4th metacarpal shaft ORIFs. We initially attempted closed reduction and percutaneous pinning, but at a month they were sticky enough that we couldn't get the reduction closed.
Why would you even operate on the 3rd and 4th?
Yeah, so we fixed the 2nd, and then the 3rd and 4th were extremely short.
When you say extremely short, how short can they be?
They were more than 5 millimeters short. And we felt that because we were there after we had fixed the 2nd, the 3rd was still persistently angulated. And
can you go back to the injury film?
Sure.
Listen, the 3rd and the 4th are basically healed at a month, right? You have to take that down.
Correct. Yes.
The overall alignment is excellent in both of them. They're a little short. I bet you at 4 weeks he can make a full fist with those fingers. Did you ask him to make a full fist at 4 weeks and see what he could do?
There was he could. There was still motion at the 2nd metacarpal shaft.
I'm not arguing that you can make a case to do nothing or to operate.
Yes.
That would probably have done okay.
Yeah.
But that one only has 25% or 30% bone apposition. That would probably heal as well. But 3 and 4 are healed.
Yeah.
And now what's the likelihood you're going to take that plate out?
Yeah, there's certainly a chance we'd have to take that plate out. We were able to get decent coverage over it. But
I'm not that worried about having to take the plates out. So Dave, that was my plan, was really just to address the 2nd metacarpal. It just, after fixing it, the height differential was pretty profound. And that's what kind of made me continue on. I made the incision centrally, so it was just through one incision. But I didn't like the way it looked radiographically after I fixed the 2nd metacarpal.
When it comes to metacarpals, if there's no rotatory malalignment, sometimes it could look terrible and wind up perfect. And so I would just say that Even the translated ones somehow heal and they do well if they have good motion, and their function is pretty good, particularly in a 64-year-old guy.
I'd have fixed those if they were short. You're already there. I mean, again, the relative downside is minimal, and the offset can really affect with a significant lag of the fingers if they're short.
Right, but you have the advantage of a month post-injury examining them and seeing the motion, and it's so unusual not to, at a month, have excellent motion.
It's going to be different though if you stretch out the index. I mean, he's going to, and again, that can change over time because you'll get some shortening of the extensors. But you know, again, if you're there and there's a big mismatch, I don't have a problem at all fixing those.
Good morning. First patient's a 58-year-old female. So that's ground level fall. This left distal radius fracture. She was neurovascularly attacked. Closed reduced and placed into a sugar tongue splint. Next patient is a 65-year-old male. Suffered a blunt injury, a piece of wood with this right small finger PIP dislocation associated middle phalanx fracture. Patient was neurovascularly intact and closed reduced and placed into a dorsal blocking splint. Next patient is an 82-year-old female, suffered a ground level fall, this right proximal fibula fracture. So I don't know if it's projecting well, but we got a ankle x-rays and a stress view, which were negative. So it's just an isolated proximal fibula fracture. Knee was stable on examination. She was just given a knee immobilizer for comfort, and the glute bearing is tolerated.
What part of the middle phalanx, what percent of the middle phalanx was fractured in that PIP dorsal dislocation?
Yeah, it wasn't really a significant portion. It was probably about between like 15 to 20%. And, you can accept up to 40 before you worry about significant instability. And this patient was stable after reduction.
Did you really put her on a dorsal blocking splint? In other words, did you tape it on only one side of the splint?
I'm sorry, can you repeat that last part?
Did you truly put her in a dorsal extension blocking splint?
Yes, yeah.
So you only taped it on one side?
Meaning, are you going to allow her to flex in the splint?
Is there tape
Well,
only on one side of the PIP joint?
Oh.
So a dorsal blocking splint can be taped on either side. If you have it active, you're not going to have it taped distally so they can actively flex, right? But does that even need to be in a splint? Another question.
I guess it doesn't necessarily need to be in a splint. Could have just buddy taped it.
But the recommendation, I mean, it's a reasonable thing to splint someone for at least a week after a dislocation for comfort and let them follow up in the office. The question is, are we clear that we understand what an extension block splint is?
Yeah, so I guess it's not technically an extension block splint since I did tape the middle phalanx as well as the proximal phalanx. I left the distal phalanx free so the patient could arrange that.
So if you tape on both sides, it's a static splint. If you tape on one side and allow motion and block extension, it's an extension block splint. Whenever you get an x-ray after you reduce it, my suggestion is to get a picture of the finger, an isolated finger x-ray, because on that lateral, I'm a little concerned that the middle phalanx is a little dorsal in relation to the proximal phalanx. And I can't tell for sure, but it looks a little dorsal. And even though the bony fragment is small, that doesn't mean you can't have some instability. So I'm worried about that. So I think before you leave the emergency room or your office, Get a finger x-ray so you could be 100% sure that that's reduced.
Thank you.
Looks reduced.
Good morning. First, we have a 10-year-old male, left-hand dominant, slid in while playing baseball, sustained his left ring finger P2 neck fracture. He was dorsally displaced, and we decided that this patient would do well with close reduction, percutaneous pinning of that P2 neck fracture. Next, we have a 13-year-old male, status post, he jammed his small finger while playing football. He has this small finger P1 condyle fracture, pardon the soft there. This was him originally, and then 1 month out, he presented to our clinic, and so we decided to do a takedown of malunion and close reduction percutaneous pinning of that fracture.
Where was the patient seen initially?
Honestly, I'm not sure exactly where.
He was seen at another pediatric orthopedic office and was contacted about a week after the injury. They showed up to my office 3 times with no insurance info and no referral and left angry 3 times. So they finally got in about a month out. The parents did, not the kid, obviously. The kid just followed him.
I mean, this is a very hard case, obviously. Was it possible, or, I mean, the articular step-off still exists there, and I know it's very hard to do, but was it just after you took it down, just impossible to make it perfect or closer to perfect?
So
Yeah.
I mostly took it down with a freer, and I mean, I chose to accept less than perfect to not make a bigger opening just because I didn't want to devascularize the piece. I thought the piece was really small, so that was my choice to kind of accept good enough instead of perfect in this scenario.
You know, Deirdre, I'm just thinking out loud. What about putting like a small X fix on the ulnar side just to kind of distract that enough to take some pressure off, and maybe the articular surface could have been improved? Did you think about that?
No, I mean, I didn't think about it at the time. And we were pulling pretty hard. I didn't think distraction corrected it. Even when I tried to put like a little bit of an like ulnar angulation on it to see if that would pull the piece up, it just wasn't pulling any further. I mean, we had it pretty free with the freer in there. You were able to like kick it up just enough to kind of get it there. The first pin we put in, we actually still had the freer in place and kind of had to work around it a little bit. So it was just kind of difficult. I think these are really hard at a month out personally. I'd almost rather them be more healed and have to do a condylar advancement osteotomy, or obviously that most ideal would be to have gotten to it the first week or so.
My 2 cents is, I think, you know, for a delayed case, that looks fabulous. And as long as you don't get any necrosis, that'll be great. He might have some swelling, but you've corrected, you know, the long axis. So I wouldn't put anything else on it. I'd take that right where it is.
Thank you. Next, we have a right-hand dominant 38-year-old male, southwest ground level fall with this left distal radius fracture. He was close reduced, placed into a sugar tongue splint. Finally, we have a 73-year-old female, right-hand dominant as well, this left with ground level fall with this left distal radius fracture. She was close reduced, ring removed, sugar tongue splint. Thank you.
Wow, excellent reductions of those wrist fractures.
Thank you.
First patient is a 53-year-old gentleman who fell outside and sustained his right distal radius fracture. He was close reduced and placed into a sugar tongue splint. Next patient is a 5-year-old male who fell at a trampoline park and sustained his left type 2 supracondylar humerus fracture. He was neurovascularly intact and taken to the OR the following morning for a left elbow close reduction and percutaneous pinning. Next patient is a 78-year-old male who fell and sustained his left distal clavicle fracture. He was placed into a sling. Next patient is an 87-year-old male who fell from standing and sustained this right hip intertrochanteric fracture. He was taken to the operating room for a right hip intramedullary nailing.
Was that clavicle fracture a lateral clavicle?
I'm sorry, what was that?
Yeah, that distal clavicle fracture, is that likely to heal or not heal?
I mean, he's at high risk for a non-union. You know, I think due to his age and comorbidities, it doesn't make sense to try to fix anything. He actually has a contralateral right type 3 AC dislocation that he's completely asymptomatic for. He actually looks more even now that he has this distal clavicle fracture. He may go on to a malunion and it may be asymptomatic, but I don't think there's necessarily an indication to fix it.
What type is that?
I think it's a type 2. So I think the ligaments attached on the distal fragment.
So what's the non-union rate though? I think that was Dr. Kirschenbaum's question.
For a distal clavicle, I think especially for a displaced one, the malunion rates are anywhere between like 30 and 40% is what I saw in the literature.
Malunion or non-union? Are we using
Sorry,
those
non-union.
All comers typically 25% is what I recall. But yes, this one's displaced and I would give it a higher chance of non-union.
This is an 89-year-old male who fell from standing and sustained this left femoral neck fracture. He was medically optimized and taken to the operating room for a left hip cemented hemiarthroplasty.
Good morning. First patient is a 16-year-old female who fell on the stairs and sustained a left elbow dislocation. She was closed reduced and placed into a posterior splint. There's a 17-month-old male who rolled off the bed and sustained an isolated left distal ulnar shaft fracture. Was placed into a long arm bivalve cast. This is a 6-year-old female who fell off the monkey bars, sustained a Salter-Harris 2 left distal radius fracture, was closed reduced and placed into a sugar tongue splint. Is a 15-year-old male, status post fall during a flag football game, sustained the right Salter-Harris 2 distal radius fracture. He was closed reduced and placed into a sugar tongue splint. This is an 11-year-old male who was injured in a tackle during a football game and felt a pop in his right hip and then another pop when he got to the bench. He came in with severe right hip pain and these x-rays showing widening of his right hip joint space. His exam and imaging were concerning and he was taken for a CT scan of the right hip, which shows an intra-articular loose body. So he was taken to the OR for a surgical hip dislocation where we discovered that that loose piece was from the posterior wall. We were able to fix it down using suture anchors. We did a troch flip osteotomy that was then repaired down.
What was the sequence of events for that?
For the procedure or prior to the procedure?
What approach did you start with, and then how did you discover it's the wall?
Yeah, so we did an anterolateral approach, then we did our troch osteotomy, and then Watson Jones to get to the hip capsule. We then were able to, we made our capsulotomy with like a Z-plasty and dislocated the hip. And we were able to feel on the posterior wall that there was that piece there.
what did you think the piece, where did you think the piece came from initially?
Where did it come from initially? It came from the posterior wall.
No, where did you think it was coming from?
I mean, my
Because you said you
thought-
discovered it was from the posterior wall.
My first thought was as from the femoral head, but we didn't see any defects on the femoral head on the CAT scan or in the patient. So the posterior wall was the leading guess going in.
Because with that story, you had heard a pop, limped to the sideline, or was another pop, which sounds like he dislocated and then relocated himself.
Yep.
The obvious place for it to come from is from the posterior wall. Unless, and plus you have a CT scan showing that the head itself looked okay. If it was not come from, so why do a surgical dislocate? I guess my question is, surgical dislocation obviously carries more risk, right, than a standard poker approach to an acetabulum, especially in an 11-year-old.
So initially, we weren't sure. We thought that maybe this was a kind of perifoveal avulsion fracture, and it wasn't very clear even looking at the CT scan. And it was really once we had dislocated the hip and we looked down into it that we did realize it was actually kind of an osteochondral fragment with the labrum attached. So it was only really confirmed after we had opened up the hip.
Was that piece? I forget what the CT scan looked like. Was it big enough where you couldn't just leave it?
We felt, I mean, there was a significant amount of delamination of the acetabular cartilage, and its bed was right there and pretty intact. We just roughened it up and used all suture anchors to suture it back down into place.
No, I mean, if you are looking at the CAT scan initially before the surgery, is that piece automatically makes you think, oh, we need to go in and get it versus getting it arthroscopically later versus leaving it alone?
Well, we thought about it, then, we're looking at the joint. The joint was clearly not congruent. I mean, it was definitely wide. One option definitely would have been to wait and, let the capsule kind of scar in and then go in arthroscopically, but we felt that this was the best approach to utilize.
Why does it still look wide on the x-ray?
Well, again, I think that there's still a significant effusion. And I mean, again, it doesn't look exactly like the contralateral side, but, again, we visualized everything and the hip was definitely stable after we reduced it. So we felt that this was what we were going to get.
Was it stable before you opened? Like when you brought the patient to the OR, was it stable?
It wasn't grossly unstable. He did have some increased internal rotation compared to the contralateral side, but it was not grossly unstable.
Is there any thought of getting a post-op CAT scan? Because that looks very wide compared to the other side.
It's also, his hips are also rotated differently.
Yeah, the x-ray is not a perfect AP here, so. Does the osteotomy for the greater trope change in a kid? Like how is it done in a pediatric person versus an adult, where you don't have to worry about physes or anything?
Yeah, we're not.
So we did.
Go ahead.
We did go through the apophysis. The cut is underneath the vastus and medius insertion, so the vastus and medius both go with it.
If you knew it was a posterior wall fracture that was in the joint, is there a way to get to that without dislocating the hip?
I think if we were certain that that's where it was coming from, we could have, but we just weren't 100% sure.
Serge, what would be the technique of that? Would you just keep rotating the hip until you could see that fragment and then grasp it, or how would you do that?
Well, if it was a posterior wall, as you go in for the acetabulum, you can, the Coker, the regular, or Gibson, whatever the approach to the posterior hip you would use, you would be able to get it out, because usually the capsule is attached to that wall, so it's just flipped into the joint. So once you come down on it, you see that you're staring at the head and there's nothing covering it. And then you just pull that soft tissue out.
You just
from
flip it back
inside.
out again.
Yeah. So usually there's a lot of cats, but I would assume in a young person, a kid in it or a young adult, there's a lot of thick, good capsule. So it's just attached to it. So it's, and that's what a lot of times causes it to look wide, is because the piece itself might be pretty small, but a whole bunch of capsule is inside there.
So Todd, if you were going to try to scope this, when would you want to, if you consider that, when would you think it's safe to do a hip arthroscopy here?
So we were discussing that, and we said that we would wait at least 4 or 5 days so that the capsule is not too leaky.
Yeah, I would consider longer than that. I mean, I think you got to weigh it if you think it's going to aid any like identifying where this is from, but most of the literature would point you more to like the 4 to 6 weeks.
So you don't worry about that piece in there for that long?
You do, but you know, if you think that you can get to it, if arthroscopically is your main option, then you know, you would just make them non-weight bearing and wait. But I agree that if you can get to this posteriorly, that's probably ideal.
And if you did scope it, you would just be scoping it to take that piece out and not fix it.
Correct. I think that's where the stability comes into it preoperatively. So I don't think it's great to fix like a big posterior wall fracture, but if there's a loose body, and foveal loose bodies sometimes can do okay, but I wouldn't do that in an 11-year-old.
Yeah, I think the main issue here is just the intra-articular loose body. I agree. I doubt that piece is big enough to cause a instability issue in an otherwise healthy, you know, kid. I think it's just more of a loose body issue, and then you have to make your decision of whether you want to wait and just take the loose body out with you know, with a scope and then have less of a kind of post-op rehab, or if you want to treat it acutely and take that piece out, you know, open.
Yeah, but I don't think the joint goes in 4 to 6 weeks. I don't think, you know, if you put them on crutches and wait, let the capsule scar so you can retain your fluid, I don't think the joint just, you know, disintegrates in 6 weeks.
I've done some trauma cases for Carlos earlier than that, and I haven't had much trouble with fluid extravasation. I mean, if you're just trying to get in and get out, get the piece out.
Yeah, I agree. That's where I think that the literature would say the timeline. But, you know, again, if it's quick and you're just taking that out, maybe a couple of weeks is all you need.
So Charlie, you think in the future, like if I saw this case, I would be tempted just to put this kid on crutches for 2 or 3 weeks and then just schedule him for a kind of a, you know, semi-elective, you know, hip scope and just kind of grind that piece down or take it out, you know, through a scope. Is that a reasonable option?
I think so. I mean, I think the scope, I think the cat, like in everything else, the capsule tends to heal pretty quickly. You're not doing major surgery where you're going to be in there for a few hours. So if your goal is to just have adequate preoperative workup, you've, you know, decided the piece is small and you're going to take it out for all intents and purposes. I mean, I think you can probably do it in 10 days. Because you're, again, there's no, you worry about fluid extravasation. Yes, if you're sitting there for 2 or 3 hours doing a complex hip case, then fluid extravasation is an issue. If you're going to, you know, put a scope in a thing and pluck out a loose body, which take, you know, 30 minutes, you don't really have to worry too much about it. And plus, the capsules tend to seal over very quickly. Think of knee dislocations, how quickly the capsule seals over. So I wouldn't be worried about it. Hey Todd, I was just curious though. I want to know, did this kid fall on his knee? He said he felt a pop. I mean, the mechanism is really.
He made it sound like it was directly from the tackle, but I don't know exactly what position his leg was in or which direction he was going.
He probably doesn't know either. Just
yeah, definitely an interesting case though.
Mm-hmm.
Yeah, I think one of the hard things is like, how do you deal with that widening? Because, you know, you can get that from an effusion, but does it warrant, if you're thinking a hip scope delay, does it warrant an EUA to see the stability factor of that? I don't know, I'd be open to the surgeons and everyone's thoughts on that.
Well, once you take the piece out and then do your, you might want to, I don't know, you probably don't want to like grind that piece into the articular cartilage, but maybe get the piece out and then do EUA afterwards. Are you talking about right now with that wide?
Yeah, I'm just wondering how you would manage that widening now, if that would push you, if you're saying you're going to go back with a scope.
From a patient experience standpoint, how do you think he would tolerate like waiting 6 weeks with that in his joint? Do they do okay usually?
I don't think it would be a huge problem now.
All right, next patient is an 86-year-old male who had a syncopal fall with a left distal clavicle fracture. Was placed into a sling. There's a 93-year-old female who sustained a fall and initially had negative x-rays, but went to dialysis and had their AV fistula accessed and was too swollen to have that done, and got repeat x-rays showing this olecranon fracture. She has a bunch of medical comorbidities and very poor skin on the left arm. So we elected for non-operative management and a splint for comfort for a week and then early motion.
He will do fine with that.
Yeah. This is a 52-year-old female, status post fall, leaving a Sweet 16 party with a left distal radius fracture, was placed into a sugar tongue splint. Is a 55-year-old female who's in MVC and sustained a right distal radius fracture, was placed into a sugar tongue splint. Is a 93-year-old female, status post fall, with a left acetabulum and bilateral rami fractures. She fell multiple times at her nursing home and is actually on hospice currently. She was found to have a large hematoma there and was actually taken for an embolization and was stable afterwards. She's going to be treated non-operatively toe touch weight bearing. This is a 50-year-old male, status post fall with a left bimal ankle fracture. Was initially closed reduced and placed into a short AO splint and then taken for ankle ORIF. This is an 83-year-old female, status post fall with a left ankle bimal fracture dislocation, as well as a fifth metatarsal shaft fracture. She was closed reduced and placed into a short AO splint. She's a 1 to 2 pack per day smoker her entire life and has uncontrolled diabetes. So the decision was made with her and her family to treat her, attempt non-operative treatment in the splint and transition to a cast.
Do poor diabetics do well with non-operative treatment?
No.
What do they get? What do they frequently develop?
Sores, ulcers.
Worse. What's worse than that?
Charcot joint. The skin was okay. There was a little abrasion over the lateral side.
You know, it's funny, even patients that don't have significant or don't seem to have significant neuropathy and they're diabetic and you treat them non-operatively, they can develop a Charcot joint. But that always worries me.
Good morning, I'm Eric Hyman. I'm one of the PGY3s from Jersey City. This is a 6-year-old male status post fall with a left type 3 supracondylar humerus fracture. He was closed neurovascularly intact, taken the next day for closed reduction and percutaneous pinning with 3 laterally based pins.
Good morning. This is a 12-year-old male, status post being hit in football in the thigh, present with this right femoral shaft fracture. It was a closed injury. He was initially placed into Buck's traction and then taken the following day for a right femur lateral trochanteric entry nail.
Now, why is the peds nail different than an adult nail?
So it's got there's more of a lateral bend off of the, at the proximal portion of the nail. It's also, I mean, it's a little bit smaller nail size. Actually, this is size 10, so it's not that much smaller. And that lateral offset is not usually your starting point's a centimeter lateral to the tip of the greater troch compared to a, usually most of the adult nails are more trochanteric entry or piriformis entry.
Why does it have to be different for a kid?
The thought process is that minimizes risk to your retinacular vessels that are giving blood supply to the femoral head.
So what can happen with a pediatric graded troch entry nail?
A greater troch entry nail?
Well, sorry.
Well, you can
the lateral entry nail. Excuse me. You're still going through a physis, right?
Well, you're still going through the apophysis there. So yeah, you can get, premature closure of the apophysis.
Or
you can get technically you can get osteonecrosis. The rates of that are pretty low. I mean, according to literature, there was a study done in, it is actually published in the Yellow Journal in 2011, showed 8 out of 80 patients, there were no complications with a lateral entry nail. So,
there's another one. Not physeal arrest, but overgrowth.
Like a valgus growth. I'm sorry, I'm not sure what you're referring to.
No, just overgrowth. Like I guess how to describe
you can get overgrowth of the apophysis too.
Yeah.
Yeah. That's all. Thank you.
Rob, is there a bad place for that proximal interlock to be, or can you put that anywhere you want?
So, yeah, I mean, you wouldn't want to place that too close to the neck. I mean, we initially, there are other options proximally to that. And if we, essentially, if we use more of the proximal options, it would have been closer to the neck. So we decided to try to put it closer to the lesser, which is the lower option. So yeah,
I would suggest that that's the ideal spot because you don't want to be in the neck and you don't want to be subtroch either.
No, exactly.
The first patient is 70-year-old female, status post MDC with comminuted right distal femur fracture. Patient was taken to the OR for right distal femoral replacement. Next patient is 87-year-old female, status post fall with left femoral neck fracture. She was taken to the OR for left hip hemiarthroplasty. Next patient is 58-year-old male, status post fall with right hip fracture dislocation. Patient was indicated for right hip open reduction and acetabular RIF.
What were all those pieces? Was that just wall?
That was the piece of the posterior wall that incarcerated into the joint. So there was in outside hospital, there was attempt to reduce these joints, but it was impossible. So the patient was transferred to our hospital. And when we did open, so there's a piece of the posterior wall in the joint. So
yeah, no, I get that part. Looking at the middle coronal, what other two things does he have that tend to poor prognosis to this procedure?
I think the prognosis is poor because the posterior wall was comminuted, and
Correct.
you know
Do you think on the middle view, do you think there's maybe cartilage missing in his acetabular dome?
I think there's the impacted fragment. So with this does impact this fragment and put bone grafts above to to hold this fragment, and we put screws to hold it in place. But probably the patient got multiple comorbidities. We open it. Maybe he would be candidate for the fixation of posterior wall and total hip. Probably these patients will need total hip replacement in the future.
I agree. Also, he probably has some impaction of his femoral head cartilage too, because it's wedged into his acetabulum right now. So he has a common posterior wall marginal impaction and fracture of the femoral head. So
there's no
depend on his comorbidity
fracture of the femoral head, but the cartilage was impacted on the head. So there's
Correct.
nothing to fix, but you can guess that these patients will develop post-traumatic arthritis.
So is there enough in here to have a discussion with him that he can't do an acute total hip for an acetabular fracture?
Yeah, I think that there was discussion about this option, but we finally decided to fix this and eventually postpone total hip replacement for future.
Keep an eye on him. He might be getting a total hip this year.
Maybe. Next patient is 58-year-old male, status was MVC with left bone forearm fracture and left non-display fibular head fracture. Patient was taken to the OR for left forearm open reduction internal fixation, and there is no treatment for the fibular head fracture. We gave him a knee immobilizer. Next patient is 21-year-old female, status was MVC with right ankle bimal fracture. Patient was taken to the OR for right ankle ORIF. Next patient is 86-year-old male, status post right femoral neck fracture, treated surgically in outside hospital over the month ago, 6 weeks ago. He developed surgical site infection. He underwent irrigation and debridement in outside hospital. It was not successful. Patient developed osteomyelitis and septic arthritis of the right hip. So he was transferred to our hospital, and we performed right hip IND and Gerstone.
What were his medical comorbidities?
The patient is very sick. The patient's got cardiac issue, stents, kidney injury, diabetes, severe dementia. So patients came with the sepsis, changing in mental status. So we couldn't even consent him. There was family consent for these patients.
No, it's a correct procedure. I'm just more of it's very unusual to get an infection after percutaneous pinning. So I'm just curious if there were other comorbidities that led to that.
Yeah, the previous cultures from outside hospital growing E. coli. And there's a lot of pus everywhere, all joint with full of pus. So.
And any critique of the femoral neck fixation?
Yeah, we can critique that. It was probably more than valgus impacted fracture, even though it was fixed. Probably surgeon outside hospital decided to do minimal procedure for these patients because of his multiple comorbidities. But it failed. The joint was almost dislocated. So we didn't struggle with dislocating of these joints. The screws were in, out, in. Everything was infected.
So what was the reason why when he developed an infection, he was never formally brought to the operating room by the initial treating surgeon to drain the hip?
They did, yeah.
They did a formal IND and even
Yes,
though-
they did formal IND. They opened everything. They INDs starting on antibiotic, but even though he never healed, he developed sinus tract, and he came for a couple days of draining pus from the hip, and family decided not to go to the same surgeon, and they requested to come to Rubberwood.
Well, they IND'd the wound. They didn't open the hip up.
They didn't open hip. They opened lateral incision. They IND everything outside of the capsule. But
Right,
when we came there,
the problem
pus
was a septic joint. So they didn't open the hip, is what you're saying,
They didn't open the joint. Yeah.
right? But it
They
was a
did
septic-
formal IND in the OR, but they didn't open the joint cups.
They knew that the hip was infected. They didn't suspect that as a collection underneath the skin. There was no.
My thinking is that they were thinking that it's surgical site infection, that it's superficial infection. So they, open the skin, IND everything, start the patient on antibiotic, but the patient is immunocompromised. He develops septic arthritis, sepsis, consequently.
Even as the hip was subluxating, they thought it wasn't in the hip.
Initially, the hip was okay, but when he came to us and we took an X-ray, there was like subluxation.
What's the take-home message in this case?
That even simple procedure can end up, with the better results.
When someone has a procedure on the hip, you're obligated to make sure there's no hip joint infection. If there's an infection, it's your job to make sure there's no hip joint infection. And if they don't want to operate it, or you don't want to operate it, at least aspirate it, because you take a case that's simple, opening the joint and draining it, and now you have a girdle stone and a disaster. So we're obligated to make sure that the hip joint is not infected.
Next patient is 58-year-old male, status was MVC, polytrauma with right femur fracture, right type 3A open tibia fracture, tibial tubercle fracture, non-display Weber A lateral malleolus fracture. The patient was taken to the OR for right femur intramedullary nailing, tibia irrigation debridement, intramedullary nailing, tibial tubercle, ORIF. Next patient is 80-year-old male, status was MVC with right femoral shaft fracture. The patient was taken to the OR for removal of hardware and right femur intramedullary nailing.
What was the sequence on the previous case of?
So the cannulated screws were done in.
No, the case before that.
So the wound, we opened the knee and put a retro nail on the femur first. Then we reduced after IND, we reduced this fracture of the proximal tibia. We provisionally fixed it with the plate, put the nail, and at the end, we fixed the tibial tubercle. It was like a shear, patellar tendon was avulsed. So we put the plate, hold all these pieces of tibial tubercle in place. And additionally, we use suture anchors to whip stitch the patellar tendon and suture that to the bone.
So that nail doesn't prevent you from fixing the tubercle?
Yeah, so we use like unicortical screws, and for the tibial tubercle, we use like 2O plate, like positional plate, and we just fix it like around the nail. We couldn't like put a screw from the anterior to posterior cortex because of the nail.
So when do you start knee motion on this?
So our plan is to keep the patient's toe touch weight bearing in a knee immobilizer for at least 4 weeks, and then we can start range of motion. Next patients is the patients with the femoral shaft fracture. Talk about these patients. Next patient is 27-year-old male status MVC with left radial shaft fracture. The patient was taken to the OR for left radius open reduction and internal fixation. Next patient is 30-year-old male status post pedestrian shock who came with right open tibia fracture type 3A. The patient was taken to the OR for irrigation and debridement and right tibia intramedullary nailing.
What approach did you use for the radius?
Henry approach.
Is there any reason, is there any advantage to that over a dorsal approach?
That was a surgeon preference. We're feeling more comfortable with going from the anterior. So that's probably was the reason. Probably we can do both, volar or dorsal.
And he looks like you plated laterally.
Yeah.
No.
You did, because that's an APO of the forearm. The plate's on the lateral
Yeah,
side.
maybe it's more laterally than anterior. Yeah.
Huh. Does it matter where you put the plate?
I don't think so.
What's the tension side of the bone?
Yeah, that's the opposite side. Yeah. So we should put on the tension side, not on the compression side. But
well, you know, even though the dorsal side is the tension side, the volar side is a better, is a sometimes easier approach. And I don't think it makes, it doesn't make a bit of difference. It's really surgeon's preference. There is also a lateral approach to the radius. That's why I didn't know what you did there, but you used the volar approach to put a lateral plate, which is a little odd, but it's reduced nicely.
Thank you. That's it.